can see it.
Can you hear me? Can you see the screen?
Yes, we hear you, we see you, you're good.
Okay. Hello to everybody. My name is Nadiv Shapira, and I work with Stephanie, and we are running First State Lipedema. First, some word of credit I want to give to 4 people. Here we are. First, on the left side, you see Laura Sunstein, a neighbor of mine. She lives in Pennsylvania, nearby, and she really introduced me to the subject of lipedema after she came back from Germany, where she underwent several procedures with Dr. Stutz, that you see here with me. So she introduced me to him, and to her I met Karen Hurd, that you see here. Karen is an endocrinologist by her specialty, and she's really the person that deserves the credit for bringing lipedema to the American map of the general population in general and to the medical population in particular. And on the right side, you see our beautiful Stephanie, that without her, we would not have basically First State Lipedema. So that's where we are. Lipedema was described actually, believe it or not, 8 years ago at the Mayo Clinic by these individuals. And in that description, they list a whole list of symptoms and findings and how you decide when one has lipedema. But actually, if you look at the 5 top variables, you see that everybody can really make her diagnosis of lipedema, because I'm not aware that any other medical entity fulfill these 5 requirements. I mean, lipedema almost entirely exclusively occur in women. It is symmetric swelling. It's not one side or unilateral, but it's bilateral. It spares the feet. You have minimal pitting edema, unless it's complicated. And very unique to that entity, it's associated with pain and tenderness. No other entity really gives diffuse pain and tenderness of the fatty tissue. The etiology of lipedema at this point is really, we don't know the different assumptions, but it's really unknown. There are 3, we recognize 3 stages of lipedema. In the left side, you see stage 1, and what's unique about it is the skin is smooth. The fat is underneath the skin, between the skin and the muscle, but the skin is smooth. Some of you feel some nodules underneath the skin, but it's very important, because if you see the picture, actually this woman has very large legs, but it's still stage 1. So the stage does not necessarily correlate with how big the patient is. Second stage is more fibrosis, and they start to have more irregularities of the appearance and the skin. And stage 3, that you see on the right side, all these indurations and this fat enlargement and the fibrosis are much more pronounced. People talk about also for types, there are 5 types of lipedema. I personally always forget which one, who is who, but it's important to know that it can appear, you can have it in the arms, you can have it in the belly, in the waist, and later I've seen some patients that have it even in the neck. Not to go too much to the science of that, but when you look at lipedema fat under the microscope, you see basically many cells, fat cells that really large, like balloons almost, and next to them small cells there. So you have both enlargement of the cells, and hypertrophy, and a larger number of cells. What is important in context of, I just showed you this enlarged fat layer between the skin and the muscle stretches the lymphatic channels that you see here. They're very delicate and stretches underneath the skin and then between the skin and the underlying tissue. And when this gets stretched, and the result often is lymphedema. And lymphedema is actually often seen association with lipedema. That's a slide from Dr. Hertz, and you see here that you can see that the hand, I'm trying to make it work. Okay, here, when you pass the finger, you feel underneath often some subcutaneous nodules, and they can be just styrofoam size, or they can be peanut or even larger, pea size or even larger. And that's what we consider the Derkun's disease that often associated with lipedema. These are often the tender nodules, and sometimes you can have actually very little lipedema fat, and most of the disease are really these nodules. Comorbidities. So often lipedema, and by the way, this is not actually only comorbidities, but also complication of lipedema. Very important, the effect on gait and mobility, how it affects the posture, and we'll talk in a few minutes about that, and subsequently can result in arthritis, and especially most commonly of the knees. It's often associated with obesity, and again, hard to say, is it a comorbidity or complication of lipedema? This lymphedema that I mentioned is often associated with lipedema, and because of the stretching and the effect of lipedema on the lymphatic channel, often we see varicose vein associated with the lipedema, and the pain and the tenderness that can be overwhelming, and not less important, the psychological effect on the women that have it. Often the issue is common patient. We see the patients is high differentiate between lipedema and obesity, regular obesity. And you see, I mean, basic lipedema, it starts often, not always, but often in puberty, because there's some close association with hormonal changes. It's painful, bruising easy. You can change, the patient can change lifestyle. I mean, eat better, exercise. It does not affect the lipedema fat. The disproportion between the upper body and the lower body, from the waist up and from the waist down. And again, how to differentiate, for example, if you look at lymphedema, often it affects the dorsum of the foot, the ankles, and sometimes higher. That's lymphedema. Also, lymphedema is painless. There's no pain whatsoever associated with lymphedema unless there's an infection or other complication. Edema associated with the venous insufficiency. First of all, often associated with the varicose vein, and you see often the discoloration of the skin. But by all means, the differentiation between lipedema and lymphedema, or edema due to venous insufficiency or obesity, it's really not difficult. That's what I mentioned before, the effect on gait. And that's, I think, it's very important, because if you see in these arrows, the stress of the body in normal people usually goes through the knees, but often because of the fat that accumulates at the inner aspect of the thigh, push the legs gradually outside. As a result, and that's called the valgus deformity at the knees, or gynovalgus. As a result, the stress is not going through the knees, which is normal, but goes between the knees. So it's more and more stress on the inner side of the knee. And that's what happens subsequently. You see, the left leg of this lady she's fairly straight. Still, it's abnormal because if that's the center of the straight, it will not go through the middle of the knee, but to the inner of the knee. And on the right side, she has marked diversion of the gynovalgus. And look at the angle between here and here. And the stress really affects the inner side of the knee. And if you see here, that, by the way, that's a beautiful study done by my mentor, Dr. Stutz. I think it's a very elegant study. What he did, he looked at where the stress applied to the feet. And patients with lipedema, it is primarily at this area, at the first metatarsal area, because of the abnormal gait. That's very common comorbidity, obesity and lipedema. I don't know if it's comorbidity or it's complication of lipedema, because these patients obviously with lipedema, because of the pain and the arthritis, they cannot be mobile enough, they cannot exercise enough to start this a vicious cycle. I mean, you cannot, the lipedema pain reduce your activity. Because of reduced activity, you are less mobile, so you gain more weight, and it gets worse and worse and worse. So you see, very important, this patient, look, a lot of the fat is in the belly, between the skin and the abdominal wall, but this patient also a lot of fat inside the belly. This is white fat or obesity fat. Another thing I want to point, look at the upper arms, and I want to point out the angle between the spine at the lower, the lumbosacral spine. Look at the angle here. That's hyperlordosis. In normal people, probably will be like that, something like that, might hits like that, and that causes low back pain very often, because the belly kind of push the body down here, and the buttocks kind of push up, and that results in this abnormal lumbosacral spine. That's it's really the lymphedema is really advanced. You see this on the feet, that's swollen, and when you're trying to pinch it, you cannot pinch it compared to normal people. When it's at that stage, that we call it lymphedema or stage 4. But I want to emphasize that I believe almost all patients with lymphedema have some component of edema, because not the entire fluid that accumulates in the legs can be properly drained. There's some overwhelming of the lymphatic channels, and they cannot drain everything, all the fluids, but in most cases, it drains some, and during the night, it gets better. And with some other methods that we'll touch on them, it gets even better. But when it reaches this stage, that's what we call lipolymphedema. Here's a patient with the lipolymphedema. I saw her 4 years ago, long time, I guess. And you see huge legs, the edema here, but she's clearly lipolymphedema. Her initial problem is lipedema, not lymphedema. That's a good example of difficult patient. She's 33 pounds. She has huge pockets of fat between the legs, at the inner thigh. As a result, she has marked gain of valgus, and you'll see the hyperlordosis. And if you want to see, I'll show you. I asked her to walk, and most of the patients that come to the office, we ask them to walk and take this consider. Look how the body, the spine tilts like a penguin from side to side. Look at the huge belly hanging in front. Look at the shaping between the thighs. She's a miserable woman. Obviously, we cannot expect her to exercise. This is a difficult situation. And this is another patient I operated on her several months ago. If you see here, here you see the feet are normal. No lymphedema to speak of, but there's this huge pocket at the inner thigh and huge pocket at the hip. And I lift it and it's heavy. And as a result, look at the edema in this pocket, which I show here. So that's a difficult situation by all means. So how we treat lipedema? Well, let's go to conservative treatment first. I think this is a very important slide. First of all, choice of food. And I love this statement: if men made it, don't eat it. Because most of the man-made food have they induce some degree of inflammation. And if you remember the histology slide from before, there's some element of inflammation associated with lipedema, so you want to minimize it. Improving the gait is extremely important. Excuse me. Keep moving is very important. Water exercise, Pilates, whatever you can do, ambulation. Later, we believe more and more the whole body vibration is very helpful to mobilize the lymphatics. And I can tell you, all the women, they have it. I've never seen one that did not like it. Especially the children really love it because they love to play with that. MLD, we try. Most of the time, the effect is very temporary and does not provide any meaningful improvement in terms of the prognosis. Wrapping is important at least to try to see if it helps. Usually it's only temporary. We strongly believe that short stretch wrapping is very helpful. We cannot elaborate too much on that. I'll mention it in a few minutes, but that helps a lot, at least to maintain a progression of the swelling during the course of the day. Everybody gets compression to the area of the edema, and the final thing that we can offer is a pump. That patient has to put the legs into this pump. There's a lymph press, there's flexitap, and they basically push the fluid up. So usually when short stretch wrapping ineffective anymore, often we have to use the flexitouch or the lymph press together. And the different kind of supplements, most the effect is primarily for anti-inflammatory the effect, and to minimize the leak of the fluid out of the lymphatic and the veins. Compression garment is a very important component, and we should look at two types of compressions. One is the elastic, as you see here, which primarily kind of hold the leg, kind of tighten on the leg, so it resists fluid from accumulating there, and by that also decrease the pain. But you have to separate. It's not the same. It's very different actually from non-elastic or short stretch, like I showed you before. I think the Juzo, I don't remember which one exactly, and this is a cool flex. And what's nice about that is you cannot stretch it. and you don't put it tight, you put it just snug. But when you walk and you activate your calf muscle, it pushes the fluid. It helps to pump the fluid up. When that fails, often you have to add the flexi touch, the pump. But this limits what we can do in terms of a conservative treatment. This is patient of Dr. Stutz. She was on very vigorous diet. You see how skinny she is, and still the lipedema is there. At the same line, what happened with the bariatric surgery? So this is an elderly woman, and she had bariatric surgery. You can see, I believe, the scar here. And it's important to understand it is ineffective. It does not change the lipedema fat. It's effective on regular or lifestyle obesity, not on lipedema fat. This is a patient I've seen a few years ago. So you see the scar. She had bariatric surgery. Look how small she is. The trunk is small. But look, she lost the regular fat from the upper arm and the legs. Most of the lipedema fat was in the legs, and they barely changed. So let's you find out that you have lipedema. What should I do? Well, there's no definitive medical treatment for lipedema today, unfortunately. And conservative treatment may help, may temper the progression, but it's not a solution. Therefore, when despite application of non-interventional or conservative treatment method, then we have to start to think about lipedema. Lipedema, as you'll see in a few minutes, has been very effective in removing the fat, reducing the pain, and improving the health of the patient. So let's take hypothetical patient. Let's call her Jane for that. So you have, let's plot a curve. Here the level of symptoms. Here is 100% symptoms, terrible situation. And it's the time scale, okay, age. So Jane found that she has a large leg at around puberty, and symptoms are not too bad. Maybe got a little bit worse, but nothing too bad. Then she went to college and things got a little bit worse, but not significantly. At the age of 22, Jane got married, and then she got pregnant. And around the pregnancy, there was definitely a worsening of the symptoms. So that kind of plateaued, not too bad. She could remain fairly active, but as usually happens, she got pregnant again, same increase of symptoms, and then plateaued. So now she's at the age of 37 or 38, and she decided not to have any more children. And over the next several years, the symptoms become much worse. And she comes to consultation. Now let's draw another line here. Let's call this line activity of medical living, or ADL. This is a term that insurance companies usually use, which means basically the normal important function in order to live normal life. So if we draw the line here, so you see, actually most of the years she knew something is wrong with her, but she managed, was not too bad. But now it's significantly worse. So now she comes and I see her. So what next? My first step is apply and optimize conservative measures. And we spend a lot of time on that, and we go one by one, and we make sure that we apply them. Now, she applied them for several months, and we may see some improvement of the symptoms, but not significantly, and it's still much worse than the ADL line. She might be lucky and the improvement will be very significant, and the symptoms now much closer to the ADL. So this patient probably will suggest, wait, don't rush to surgery. This one, she's so symptomatic compared to the ADL that we have to consider surgery. So why it is important to apply and to optimize conservative measures? One, because maybe surgery, at least for the time being, will not be necessary. And if you can wait a few years, maybe we'll have a better method to treat it. Also, we should do that for patients who are too high risk for procedure because of other medical problems. So first, we have to do that. Number two, we have to convince your insurance that surgery is medically necessary. And the definition is when conservative treatment doesn't work and it interferes with the ability to live normally, it is by definition medically necessary. And three, and not less important, we really want to see, and Stephanie touched on that, we really want to see a change in your lifestyle. That's important because I've seen so many women in conferences that had lipedema, they had lipedema, they had surgery, they did not keep good lifestyle, they did not keep good diet, they did not keep all the measures that they were supposed to keep, and they look and they are very symptomatic. So there should be this is disease that we don't know the origin. So surgery is not the solution. It's part of the solution, but it really should come together with your contribution. Quickly, conservative treatment, I separate it like between diet. Number one is diet. So we spoke about anti-inflammatory diet. I will not go into the details. Keto, paleo, RAD, Mediterranean. Stephanie is expert in nutrition, not me, but we know enough and we see marked improvement with anti-inflammatory diet, usually not to the point that they don't need surgery if they're advanced. But if they're not very advanced, often it takes them and they can really maintain it and they really do not need surgery for the time being. Intermittent fasting is highly recommended together with anti-inflammatory diet, and with adding the intermittent fasting to the anti-inflammatory diet, you really can see significant weight loss. And all kind of supplements, Dr. Herbst has a whole list of them and they're very effective. We really recommend bioflavonoid like the osmine, vasculera, mucinex to loosen the viscosity of the edema, etc., etc. Decongestion is the other part of conservative treatment. Manual lymphatic drainage helps very temporarily. Some people maintain it. Many of them do it to themselves, and it helps, but it's not the solution, unfortunately. Bandaging and then helps the same way. Compression garment is a must. Whole body vibration is, as I said before, it's really enjoying. They really feel better. 15, 20 minutes on that in the evening, they really feel better. You have to watch though, if you have knee problems or bad arthritis, it might be, we do not advise it. Short stretch rep, I told you before, basically you use the short stretch to improve the efficiency of your own natural pump, which are the calf muscles, and compression pump. So let's go back to Jane. We saw Jane here when she was 32. She came to consultation. She applied the conservative treatment for about 3 to 6 months, and she was very lucky and she really improved. And I said, Jane, let's meet again in a year, or call me when you feel any different. If she's not lucky, the improvement was not significant, then we have to start to think surgery. So let's talk about surgery. That's the old part of that. Until the end of the 20th century, lipedema was considered primarily as a cosmetic aesthetic dysfunction. So it was approached like a cosmetic surgery. They used dry technique, large cannula, crisscross of the liposuction, and often there were destruction of the lymphatic channel. The result was unacceptable, and many developed secondary lymphedema. Then in the 1990s, Conley applied the term of lymph-sparing liposuction, which aimed to do the procedure without damaging the lymphatic or spare the lymphatic. And in 2002, Rapridge and Settler presented a successful result by using lymph-sparing liposuction in lipedema patients. And several years after that, became kind of part of the German Society of Lipology guidelines for lipedema, and gradually it became more popular. Unfortunately, not that much in the US, but much more in Germany and in Europe. Just want to explain you see on this panel, you see that this. I want to show you why it's so important to do lymph-sparing liposuction. This is the skin, and this is the muscle here, okay? And this kind of a fibrous layer between the skin and the muscle, and the fat is at this level, and much more between this layer and this layer. And this one that looks like that, but often it becomes 10 times wider, the difference between here and here. And you see all the lymphatic channel, these nice threads here, this between here, the skin, and the muscle. And if you go and you rough with that system and you destroy it, most likely you'll end up with some lymphedema of the skin. And if you rough with this lymphatic channel, the collector, then you really have trouble. So it's so important to perform it in lymph-sparing fashion. Now, two methods for lymph-sparing. One is the tumescent liposuction. The other one is water jet-assisted liposuction. I'll show you the tumescent. Basically, you use very large. You can use like 8 liters of physiological solution like normal saline or lactated ringer. You mix it inside some xylocaine or lidocaine or whatever local anesthesia, and you infuse it to the fat tissue and in order to make it swell. That's the translation of the word to tumesce is to swell. So by swelling, it kills many of the fat, and it kind of reduces the force that connect between them, and then you come with a vacuum cannula and you suck it out. The water jet assisted liposuction, you infiltrate much smaller amount, maybe 2 liters, and use the same small cannula, but you just infiltrate the area just to provide adequate anesthesia. And then it's called water jet because the cannula ejects like fan-shaped jet of water that separates the adipose tissue, and at the same time it suctions it, okay? I want to show you here. This is how you do the tumescence. So you swell the tissue, swell, and then you come and suction it. Now you come with the suction, and you remove it, and you remove as much fat as you can. Excuse me. This is the water jet. So you give enough to numb the area, and then you switch to another cannula, same size. Is it moving? No, it's not moving. Okay. Okay. You just infiltrate the area. You don't try to swell it. And it gets absorbed by the fat cell, and then you suction them out. So this is basically the wall or the water jet assisted liposuction. That's my favorite method, but I want to tell you that both are very effective and nothing can be said. It is not really objective information that one is superior to the other. So I think it's mostly preference of the surgeon. So you can see the cannula of the water jet, the jet comes like that, can shoot out, kind of like pulsation of the water jet. So something this video doesn't work, and so it comes out and suctions to these holes. Well, it doesn't change. So basically, that's a comparison. I don't want to elaborate on that, but I think because I use less local anesthetics, you can do more liposuction per procedure. So here, what we start with, that's what we start with before surgery. We mark this patient. We know what we're going to do. We take this out. Usually, we take one or two more of these canisters. And how we do that? So first, we mark the patient, we wash her, we cover her, and we mark the patient. Then she lies down, and you see she lies on the belly, but she can lie on the side, on the belly, on the back. How depends what's appropriate for what we are doing. And here on the left side, we just give some numbing, like the dentist give us, few spots, okay? Then we make a tiny hole with a knife, and we put a cannula that will infiltrate the local anesthesia. Then we start to suction. So you see the fat start to come through the tube, okay? And we suction different areas. Here she's on the side, here she's on the belly again, until we don't get any more fat, and we stop. We recover these wounds, and we squeeze the fluid out, and we let it stand. A lot will come on the floor. The more comes out, better it is because it doesn't stay inside. And a few days after that, she can start the manual lymphatic drainage. She has to keep the garment for 2 weeks, 24/7, and then maybe half a day. And we encourage them to ambulate and to move a lot. So basically, I took this number of one of my cases. That's the machine that we use. So we infiltrated a little bit numbers. We infiltrated this patient with 2 liters of local anesthetic. We use additional 12 liters for irrigating it out. So we total introduced 18 liters. We filled up 6 canisters. You see this, one of the canisters has 3 liters inside. So 6 canisters, it's 18 liters. The infanatant, the part here, which is mostly not fat, it's probably the fluid that we use to irrigate the fat. We have 2,400, 2.4 liters, times 6 is 14.4 liters. And the fat part is 600 milliliters, times 6 is 3.6 liters. So you can see that basically that represents most of the fat that we took out. Now, probably it's a little bit liquefied from the irrigation solution, so maybe it's a little bit less than that, but at the same time, a lot drained on the table, on the floor. So I would say we usually take around between 3, maybe 4 liters. And how much is too? Many patients ask, how much can you take? Well, there are some limitations. We don't want to load the patient with too much fluid because it's a lot to handle on the circulation. We don't want to give too much local anesthesia because there's some toxicity associated with local anesthesia, and a lot of it will be absorbed. And the other issue that I learned with time is that it's very difficult for the patient to remain comfortable for a long time. Does it hurt? A big, big issue. Well, first, what is pain? Very difficult to define pain, but we should look at pain as some stimulation, nauseous stimulation that brings up subjective experience. We have some subjective response that has both physiological and psychological response. So on one hand, we feel the unpleasant sensation, like pain, heat, or whatever, and that triggers some behavior. We withdraw the hands, we scream, we get angry, whatever. How we can deal with that? So what can you do about the pain? So first of all, we can deal with this pharmacologically by analgesia, like local anesthesia or general or anesthesia. We should control the anxiety, we'll talk about that in a minute, and some control of our stress, excitement, fatigue. And Stephanie mentioned that before. We hate the patient come tired because they come tired to surgery, they're jumpy, they're very stressed, they're on the edge of the time. So that's the way the surgery was done in the past. Okay, that's from the 17th century. So this guy, his surgeon, I look a little bit different than him. He cut something with a saw. This guy digging into the skull. I don't know what the head is looking for. And I don't know what even going on here. We do it better today. So we have general anesthesia. We knock the patient totally out. He's totally dependent on the anesthesiologist. We can apply the anesthesia onto the part of the body, like regional anesthesia, like subdural or epidural. Very commonly used now conscious sedation. And some people do the wild procedure with conscious sedation. But here, patients, we don't place airway, but we give enough to knock the patients out. I like local anesthesia, and I'll tell you why. Because I think the general anesthesia, regional anesthesia, or twilight anesthesia, it's not necessary. I think it's an overkill. On the other hand, I want the patient to be fully awake. I want the patient to be able to move when I ask her. That's good for DVT prophylaxis, to minimize respiratory problems, for many reasons. And I want the patient also to give me a feedback, what she sees, if she has pain or not. I can address it. And also that enables us to do it as office procedure. So you see, I'm operating middle of my surgery, and I talk to the patient. I ask her, do you feel it? And if she feels, I can address it. I tell you in a second how. But it's so much healthier. I want the patient to be part of an active participant in the procedure. So is it possible to do the water jet assisted liposuction while the patient awake, comfortable, and relaxed? First of all, the relaxation part, I really want them to sleep well, to have a good breakfast, drink during the case, relax. That part, I mean, we keep them awake. That part is on me to make them, keep them comfortable. But I do not think it's an oxymoron. What we do first to do that, first, that's something that I start to do really after I did Stephanie's procedure. She mentioned to you before that she had pain. So I decided after that, I take different local anesthetics to see from 1 to 6, and I do a test the day before surgery. I inject them underneath the skin. And after half an hour, I pinch them and I see which one is the most effective. So the patients that we're going to use effective local anesthesia, and I feel comfortable with that I will minimize the pain. And then the other thing, nitrous oxide, we started to use it, I believe, almost 2 years ago, and that's very effective to control anxiety and pain control. We give it only when patient asks, but when she asks, we are very, very generous about it. And I'll tell you, 5 inhalations make them feel much more comfortable. And we can repeat it every few minutes because nitrous oxide is safe because it's immediately metabolized by the body. So after a few minutes, it's not in the body. And look what he did to us. I know it's a little bit detailed, but I want to emphasize one point. This is the time until August 2 years ago, almost 2 years, that we did not use. Here we did not use nitrous oxide. So we used a large amount of local anesthesia, anesthetic, ropivacaine, carbocaine, doesn't matter the details, in the infiltration solution, also in the irrigation solution. After August 2018, no, I think it was 2000, no, I think it should be 18, that's my mistake. I think it's my mistake. Nevertheless, we do not use any ropivacaine or carbocaine in the local anesthesia, only for infiltration. Instead, we're using nitrous oxide. And look what it did to us. Look how much ropivacaine we used before, 248 milligrams per on average, 127, 496, 254. So adding the nitrous oxide enables us to use much less local anesthesia. Why it's good? Because it's safer, because less medication, it's just safer. They have much less nausea. They have much less hemodynamic changes when they stand up after surgery, immediate after surgery, much less lightheadedness or headache, and they can leave the office much sooner. And look, with all that, heart rate is slow, and oxygenation is good, and they remain very stable. Now, we all hate pain, but pain is essential and important protector from injury or damage for the patient. That's why pain is so important, and damage can be caused also by surgeon. So if the patient is in pain, first let's check, is it my fault? In other words, is my cannula a little bit too deep or not in the perfect place? And immediately can correct it. Now, if the patient is tense or anxious, we use nitrous oxide. If still pain, we can give him some more infiltration solution, that one that has a local anesthetic. And they always can something, a pain medication or some relaxation medication. So what else we do during the procedure? Keep the patient comfortable. First of all, she can drink to the procedure, she can snack, jogging, gossiping. You wouldn't believe what gossip I sometimes hear. I'm here and they think I don't hear, but I hear everything. And so they gossip, drink, and the fat is coming out. A lot of TLC, tender loving care, okay, by the nurse. Look how much fat is coming here to the tube. And when necessary, nitrous oxide. And that always makes the patient happy. When I show them, you see my right hand here is pinching the skin where I finished to remove the fat. The left one, the skin that did not touch yet. So she loves to see it, to see how much you remove. And when she sees this canister with the fat on top, she's really happy. So we're not trying to make them dance and go crazy with the nitrous oxide but enough comfortable to do the procedure. That's my almost last slide. It's very important to go with this message. If you remember Jane, the case of Jane that we spoke before, the aim of the procedure was not to make her beautiful. I don't dismiss the importance, but when we talk to insurance company and we come to surgery, cosmetic improvement, I can tell you, you will have some, but that's not the goal. And the more you have, it's like a bonus. So that's the emphasis. And my belief is that to try to make it really to tighten the skin to address these issues at this point, as when the lymphatics are stretched and abnormal, I don't support that. The purpose is to enable her to resume the ADL, to resume activities of daily living, be able to walk, improve the gait, reduce the pain, eliminate the pain, stop the arthritis. And it's amazing how often patients after surgery, because they can stand better, the arthritic pain, the pain in the knee really resolved, almost totally gone or totally gone. Wanted to go back to work, to be able to exercise, to live productive life, and to try to stop the progression of lipedema. and very important to improve depression and the anxiety associated with lipedema, because it really improved the self-esteem. Still, improvement for cosmetic improvement occurs, and you see this patient came here. I marked it for the first procedure. We did the inner legs and the hips, and then she came later. After that, we had the arms down. You see the size of the arms here, and it's the arms, I believe, from the dates, I think it's 4 months later or 5 months later, they're much nicer, much smaller. And here she's going to have the belly procedure. So you remember the patient that you mentioned before with the genu valgum and the abnormal weight distribution that caused this terrible arthritis? So this is how the weight distributed before. You see at the first metatarsal here. Here it's much more normal, much more even. At all these points, her weight is distributed at all these points. That's a beautiful study by my mentor, Dr. Stutz. Very elegant. And that's why I think the pain in the knees often reduces, and often they will not need a knee replacement. Let me skip that some results from our from lipedema women in America, to show you that all the factors, spontaneous pain, tenderness, all these variable, subjective variables, they came from like 4 to 1.4, or the cumulative from 31 to 40 to 31 to almost 14. Significant symptomatic improvement. That shows you how the cumulative symptomatology improved. And that's basically take you through the whole case. Here we measure, we mark the patient for surgery. Here I do the procedure. Here she's hugging her new baby here, the canister, and that's what I insist to get at the end, a nice hug. And